Alors, nous avons actuellement, on enchaîne maintenant avec une session lunch and learn concernant les salvage intervention dans le choc cardiogénique. Alors, à mes côtés, notre président de la Société de cardiologie.
Alors, c'est lunch and learn session. You can take your lunch. You have 5 minutes for that. We take a lot of time and we are really in a hurry. And it's our pleasure to have a common session with our friends, with the Saudi Arabian Cardiac Interventional Society. We have the president of this society, Wa'il Al-Qashqari. It will be an excellent session. Take your lunch, 5 minutes, and we will start. And I invite the moderators to be here with me.
A great meeting here, and I would like to thank Dr. Salim and the entire scientific committee for the kind invitation. Without further ado, our session today will be, like some actions, cardiogenic shock and tabbing cardiogenic shock. And with our first speaker, Dr. Khalid Al-Harbi. Dr. Khalid Al-Harbi is a consultant in intervention cardiology at the King Saud Medical City, one of the biggest centers in Saudi Arabia, and they are really specialized in all the mechanical support and the complex intervention. Khalid, the floor is yours, and show us your beautiful lecture.
Okay, thank you. Assalamu alaikum. Good afternoon. I'm happy and glad to be here in beautiful green Tunis. It's my pleasure to be here and representing the Saudi Scientific Interventional Cardiology Society. Okay, my name is Khalid Al-Harbi. I'm interventional cardiologist from King Saud Medical City. Today I'm gonna present complex PCI in cardiogenic shock. I have no conflict of interest to declare. So first we have to define what is complex PCI. I just found this illustration from Jack, which was taken from British Society of Interventional Cardiology. They defined the complex PCI based on patient factors as age, female sex, prior history of stroke, any peripheral artery disease, left ventricular dysfunction, and chronic kidney disease, as well as procedural factors like left main coronary PCI, three-vessel PCI, dual access, use of mechanical circulatory support, lesion length more than 60 millimeter, and rotational atherectomy during procedure. Based on all these factors, we have to measure and calculate our MACE and the mortality based on that one. So our patient, he's a 46-year-old gentleman who had a background history of bronchial asthma. He was presented to the ER with history of severe retrosternal chest pain, which started 10 hours prior to ED presentation. His ECG showed anterolateral ST elevation. His vitals, his blood pressure was a borderline, 95 over 60 millimeter mercury. His tachycardic of 135 beats per minute, and his satting well, 95% on room air. His VBG showed a lactate of 3.3, so that's indicate the patient is hypoperfused. His echo showed LV ejection fraction of around 40% with apical and anteroseptal hypokinesia. So cath lab was activated. And as you can see here, the image, the patient had a significant distal left main lesion, occluded LAD, and severe osteoproximal LCX disease. So the lesion was crossed with the cyan blue, and also you can see here ballooning of the left main LAD. And then we have restored the flow in the LAD. And we called the cardiac surgeon at that time. And due to a procedure going in the OR, so we just decided to proceed for a PCI. So our patient, he is in stage C, sky shock. As you can see, patient is hypoperfused, borderline blood pressure, and he is tachycardic. Then we think about if this patient needs any mechanical circulatory support. His LV is around 40%, his syntax score around 27, 28. His systolic blood pressure is less than 100 millimeter mercury. He had a STEMI at presentation, and he had more than 2 vessel revascularization. So our patient is strongly advised to be on mechanical circulatory support. So just touch base on this pilot study, DTU, which is the first study testing whether the LV unloading and delay reperfusion in patient presenting most specifically for anterior ST elevation myocardial infarction is safe, feasible, and reduce infarct size and improve prognosis. But also we need another more clinical trials supported that pilot study. So we use ultrasound-guided femoral access. That will reduce the complication and increase the time to cannulation, increase both the overall success and first-time success rate, and also you can identify if there is any calcification or stenosis at the puncture site. So our patient, so what is the technique that we want to use, the next step? So our patient had a distal left main disease, ostial LAD disease, and also side branch, the LCX. So the patient has a Medina 111. So this algorithm, just to describe if the patient had unprotected left main lesion, either by angiography, IVUS, and MLA of less than 6, or by physiological study. Then if the patient is candidate for CABG or not, and then based on syntax score, and if the patient had a true distal left main lesion, and if the patient had, if the patient eligible for a PCI or not, and then if it's distal true bifurcation left main lesion, so the DK crush is the best for this patient compared to provisional stenting. So this is a step-by-step description of DK crush technique. So first you have to wire both limbs, then predilate both, then you have to put a side branch stenting, then crush that stent, rewire, first kissing balloon, and then main vessel stenting, pot, side branch rewiring, and then final kissing balloon, and then repot. So this is very important just for those steps to be don't kissing before rewiring. This is very important. And also you have to remove the balloon of the stent and the wire before crushing that stent. So this is just some important point in DK crush technique. So that's in DK crush 5, which showed a better outcome in the first year in DK crush group compared to provisional stenting. But after that, in second, third year, they have almost the same result in stent thrombosis. That's mainly for distal left main disease. So our patient, we just pre-dilated the LAD and the LCX using 2.5 semi-compliant balloon. So this is the first stent, 3.0 by 30 in left circumflex. And you can see here before that our balloon, the NC in the left main LAD. And then we took the wire and the balloon of the stent, and then we crushed that stent with a 4020 NC balloon. It should be 1-to-1 balloon to vessel. And then rewire the LCX. After that, we did the first kissing balloon. And then we used the IVAS, as now it is indicated to be a class 1A for a complex PCI and left main PCI also. IVAS showed calcification in the distal left main and osteoproximal LAD. As you can appreciate here, we are coming now to that one. As you can appreciate here, this is the osteoproximal LAD, calcified. And also you can appreciate the stent in the LCX is coming now. So we used the IVL 3 by 12 millimeter, as it is effective in modifying the lesion and it is safe. So we stented the mid to distal LAD with 275/18 millimeter stent.
You did sorry, Khalid, you did the shock wave after putting the stent?
After putting stent in the LCX. And then we put along 3523 stent left main to LAD. And then we did the first put using 4515 NC balloon. Then recrossing and the final kissing balloon with 35 by 15 in both LAD and LCX. And then the final pot with the 4515 NC balloon. And this is our last, final angiogram. TB3 flow, LAD, and LCX. This RCA, we just done it after after fixing the left main LAD LCX. You can see 50% stenosis in proximal, 60%, 70% in the ostial PDA. So after we finished the procedure, we repeated the ABG, so the lactate is 1.9. His blood pressure was 130 over 70 millimeter mercury. So the plan was to remove the impella using a 2 ProGlide, and the patient was stable and shifted to CCU. And thank you for your interest.
Thanks for this excellent case. We'll have the discussion at the end of the session. I think that such a case will raise a lot of questions. And it's our honor and pleasure to have the president of the SACCC Society, Professor Wael Al-Qashqari. He is an interventional cardiologist doing a lot in Saudi Arabia. And as you see in Saudi Arabia, they have a lot of unimaginable facilities that we don't have in Tunisia. The impella, you have the LVAD, we started the LVAD for the chronic cases, and you have facilities to do IVIS, FFR, all interventional procedures. So the next talk in this session is about is TAVI in cardiogenic shock patients. You have patients with complicated procedures, and they are doing a lot of good job in Saudi Arabia in TAVI patients and in complicated situations. The floor is yours, Professor Wael.
Assalamu alaikum, good afternoon. It's my pleasure to be with you. My talk is it's a big name, but actually there is a lot of publication regarding this important topic, and I will try to make it easy for you. The no conflict of interest, and that's my nice picture in. So the transcatheter aortic valve replacement in patients with cardiogenic shock. I will go quickly with what we have for publication, and then we'll show you a couple of nice cases. It is a common in male, rather, comparing to female, and the majority of patients, they have coronary artery disease. So it's make logic that a patient with aortic valve stenosis, why they go to cardiogenic shock? Unless they have a coronary artery disease, or they had a trauma like surgery, or something provoked this stable aortic valve stenosis. In this previous study I mentioned, there is 30 days mortality is 33%. Very sick patient and very high mortality. The mortality compared to elective TAVI is 7.7 in the elective TAVI. So that's almost 1/3 of the patient, they die on admission. The predictor of mortality in this study was low cardiac output and the presence of acute kidney injury at presentation. Estimated 1-year survival is only half. So half of them, they live up to 1 year. In emergency TAVI, and almost 83% in elective patient. So it's a serious condition. Patient with aortic valve stenosis comes with cardiogenic shock, mortality almost at presentation 1/3, and only half of them, they survive up to 1 year. Another publication published recently in 2022, I just quote the important part of it, patient who survived the first 30 days. The people who survived the acute event, like survived up to 30 years, they had similar mortality rate to other who not had a cardiogenic shock. This means if you are able to make them survive the first 30 days, they will have a similar outcome to the elective TAVI. So in the previous, the one that I mentioned before, so this is the first study that patient, the 1 year mortality was driven by the 30 days mortality. This means if I'm able to make the patient survive the first 30 days by aggressive therapy, then he will survive, he will have a similar outcome as an elective TAVI. So the admission, the first 30 days, do your best as an interventionist. So in this study, which is included about 30,000, they look at the registry and they found out of 30,000 TAVI, there was a 5,000 patient who had cardiogenic shock. As you know, that it's very difficult. You know, some of this studies done before, and some of the patient was done like 5-10 years before the publication of the SKY shock. So the definition of shock is very soft in all the publication about cardiogenic, TAVI cardiogenic shock. What I mean, are they in class C, SKY C, or B or A? We don't know. Maybe that's why we have a variation in mortality between the different studies. Let's say that by definition, acute pulmonary edema, soft blood pressure, this is the most common definition used in all the publication. In this paper, again, the mean age was 75. Remember, the European Society of Cardiology guideline, the inclusion for TAVI was 75 and above, and the American was 65. So all these people, they are at the, let's say, the good age for TAVI. But why they come with cardiogenic shock? This means they have something provoked. This means that mostly coronary artery disease. Usually AS is stable, but the presence of coronary artery disease make them sick and come with cardiogenic shock. The majority of the mortality was during, again, the first 30 days. However, 1 year mortality was similar if they survived 30 years. So this means what? The message. This patient, they have coronary artery disease, and if you make them survive 30 days, the outcome will be good. So make your all effort to make them survive this 30 year. So again, what the key message from the previous 3 studies in hospital and 30 days mortality were high in cardiogenic group. Coronary disease common in this group. Intensified aggressive medical therapy and follow-up in the first 30 days as a prognosis is the same between group after this period. So how to manage TAVR in cardiogenic shock? You have to have a cardiogenic shock team, and this is nicely illustrated by Khalid, which include CV ICU consultant, cardiac anesthesia, echocardiographer, heart failure consultant, intervention cardiologist. This is the people, if they sit together, they will improve the 30 days mortality probably in such cohort. You have to have different TAVR platform. Why I'm saying so? The evolute you don't need to pace. While you can put it in, heavily calcified valve, but Edward, you have to pace 180, and probably you cannot be able to put it in heavily calcified valve because of risk of complication. You have to have different mechanical support, Embella and ECMO and ECBella, and now there is a new device coming soon where you can connect it to the balloon pump instead of the Embella console, and Hatim will highlight about these things. So case number 1, 75-year-old male patient, known case of diabetes and hypertension. His Sky shock stage 3, his mean lactate is high, and he's hypoperfused, soft blood pressure 85 or 75/40, pulmonary edema. ECG, this is a very important thing. ECG showed dynamic ECG, STT changes and high troponin. His echo revealed LV dysfunction. You will see the echo, and it's about 25–30%, and it's a severe aortic valve stenosis. The mean pressure grade is 29. That's a low flow, low gradient aortic valve stenosis. This is his sick myocardium. The LV is barely moving. And this is his angio. Is like diffusely diseased, and there is left main, as you can see, and diffuse LED disease, and circ subtotal, and RCA is severely diseased. So how we approach this now is non-STEMI in a shock state, and is it the aortic valve stenosis giving the symptoms, or this carotid is giving the symptoms and the problem? Troponin is high, acute coronary syndrome. This means you have to treat the coronary first, and you do the TAVI after. But how are you going to do such complex cases that going to need a rotablator or shock wave without putting Embella? So the Embella, it's unload the LV and make you work peacefully. Yes, the blood pressure will not be 130, 140, but it will be good enough to give you support to do the procedure. I want to draw your attention here. You can see there is a wire. We put the Embella, and then in the other picture there is Embella, but you see there is another wire near the Embella in the LV. So that's a 35 wire. We kept it there. In case patient crashed during the BCI intervention, we can go immediately with the TAVI that is already the valve loaded, and the valve is ready on the table. And that the 35 wire, I can quickly put the big tail, and then I put the stiff wire for the TAVI. Then I put the TAVI immediately in case he crashed. So the BCI here done successfully. Anyway, so again, now this is the LED done successfully and peacefully with the presence of the Embella. The Embella, probably Hatim, he will tell me it's deep inside. I agree with him, but now is like our leg is shaking. We are focusing on the LED. So now left main LED was done. I don't care about the circ and RCA at this moment. So then we implant the valve peacefully from the first attempt. Very important, you don't repeat the implantation. You have to do it from the first attempt you don't need to be perfect, but luckily this patient, the level of the valve implantation was shallow. So you want to avoid why we implanted high. It's not a cosmetic surgery, but because you want to avoid heart block in such or left bundle branch block in such patient that who need all the resources of his LV and all the power of his LV. So that is the case number one. Case number two is the opposite. Patient is 78-year-old, admitted with pulmonary edema and sky shock stage 3, troponin more than 6,000, some dynamic STT changes. But he was very sick to allow us to go ahead and put the Impella. And honestly, when we did this case, we had a nice platform. Navigator from Abbott, maybe Abbott people, they will be happy here, that this device is easy to implant and there will not cause any hemodynamic compromise during the deployment, i.e. there is a mechanism in the valve that will continue to allow you to have a blood flow through the valve while implanting. So you don't need, like Edward, the pacing, 180 beat per minute. You don't need evolute here when you deploy the valve. In the first 1/3 of the deployment, the blood pressure will drop. The Navigator, they have a flow mechanism that the blood pressure honestly, I just started to use this over the last 6 months. There will be zero drop in the blood pressure. I will not say zero, but there is no significant drop in the blood pressure. So this patient, what we did, that's his coronary. Again, you see, if you look at the end of the image, when the dye go away, it's like the fish backbone. السمك حق حلق الواد يعني. This is the Navigator implanted successfully. And the good thing about Navigator, the cell is too large. So you can easily access the coronary. So now we access the coronary. All this in the same sitting. You can see the heart is not moving, guys. Very sick patient. So the Impella also, we can put it inside this valve easily. But we did, you can see a faint dark line on the wire. This is not a rotablator. It's not a rotation atherectomy. This is directional atherectomy, what we call the CSI. So we did the directional atherectomy, and then we implant the stent. Patient improved and successfully went home. So this is the end of my presentation, and we are welcome to receive any question at the end of the session. We invite you for our couple of meetings in Saudi Arabia next year, if you allow me, Dr. Salim. The SAS studio, the Virgin number 3, the journey will continue. That's in February, and then TCT plus Middle East. Thank you very much.
Thanks a lot for this amazing 2 cases. And we'll move forward. You've seen 2 cases with Impella implantation. We don't have Impella in Tunisia, and it's our pleasure to have a Tunisian speaker. He is in Saudi Arabia now, dealing with cardiogenic shock, and we'll have Impella in practice by Hatem Alwi.
Just to let you know that Hatem is the highest number of Impella and mechanical support implantation in Saudi Arabia, and his center doing amazing job. In fact, in TCT Middle East, they will have the entire mechanical support session.
Thank you so much. Thank you so much, Dr. Wael, for these kind words. And it's really my great pleasure to be here in a Congress that I really missed, and I missed for many, many years now. And I want to thank the organizational committee for having invited me. I've been given the talk about Impella in practice, and I'm not talking about any clinical evidence behind or supporting the Impella in practice. It will be mainly some key points, some key messages that I believe they can be very, very helpful in case we want to start or maintain a successful Impella program. And personally, some key messages that I really wish I have known before we started our program, rather than to know them and to learn them on the ground, and sometimes very, very painfully. So to start an Impella program and to maintain it, I think we really need to know the device itself, to have a deep knowledge about the mechanism, how the device works, to have some proper criteria to select successfully the patients that are for Impella support, and to have some best practice knowledge about Impella implantation, post-implantation management, and it's always very useful to have some tips and tricks to be able to handle some troubleshooting in case we have an issue with the device itself or its interaction with the patient. So we'll start with the device itself. You know, in the market now, we have multiple Impella devices. For the left system, we have the Impella CP, the surgical Impella 5.5. For the right system, the right side, we have the Impella RP and the Impella Flex for the insertion through the jugular. But for a matter of time, I'll just focus on the Impella CP here. So the main, I would say, component of the Impella is the pump. And the pump is composed of, there's no light, so we have a motor that is driving the rotation of that impeller. And from here comes the name, Impella. So this is what we have usually in any water pump. We have a motor with an impeller, and the rotation of this impeller will suck the blood from the inlet through the cannula, and it will eject it through the outlet from there. And you see in blue, this is a schema, but this, to avoid the blood entering the motor housing, we will have a purge system that will inject forcibly a solution that has to be either sodium bicarb or dextrose with heparin, never normal saline, because normal saline will create corrosion. And you need the blood not to enter the motor housing to avoid having clots or motor corrosion. If we zoom out now, the rest of the system, you have distally, so distally you have a 6 French pigtail that will serve for stabilization of the system. Then this pigtail will be connected to the inlet area through what we call a teardrop that will be very important for our echocardiographer to see in the echo, to be able to measure the distance and to assess for the position of the impella inside the LV. Then you have the inlet area that is connected to the cannula, which is a 14 French cannula with, as you see, an angulation of 30 degrees there, and a very important radio-opaque marker that we will use to position ourselves in fluoroscopy. It is continued with the outlet area and then the motor housing. All that segment that you see is a 14 French segment. Then it is continued with the catheter shaft, which is a 9 French catheter, with the repositioning system, with the repositioning sheath, the sleeve, and all will be connected to the console. And this console will allow us to select the level of support according to the RPM. We have 10 levels of RPM. And very importantly, we have this screen. We have actually 6 screens, but the most important screen is the placement screen, where you will see up here in red the pressure in the outlet that has to be an arterial pressure. In gray, the LV calculated pressure. It's a calculated, it's not a measured. We have only 1 fiber optic. And down we have the motor current in green. Here you have the flow, the average flow, systolic, diastolic flow, and many other parameters actually. But what is really very important to understand here is that the level of support doesn't depend only from the rotation speed. It depends essentially from the pressure difference between the inlet and the outlet. The more we have a gradient of pressure, the more difficult will be for the impella to suck the blood and to eject it. And at that, the less we will have support and the less we will have flow and motor current. The less gradient we have, the easier will be for the impella to suck and to eject, and the more flow we'll have and the more motor current we will have. And this is what we have actually during the systole and the diastole. blue is the gradient of pressure. So during the diastole, we have a high gradient. So it's difficult for the machine to work. So low flow and low motor current. During the systole, it's the opposite, no gradient, so high flow, high motor current. And that's what will explain that sinusoid form that we have in the motor current wave. And this is actually very important later on to troubleshoot the problems of positioning. For example, if we have if the impella is fully in the aorta, we'll have only 2 aortic pressure curves and a flat motor current curve. If it's the opposite, the impella is down, we will have 2 ventricular curves and a flat motor current curve. This is an example of a good positioning. You see that sinusoid motor current curve, ventricular in gray, and aortic in green. So now how the impella will work, how it will help the patient. So first of all, we have 2 main mechanisms here, and the most important mechanism is the unloading, actually. So the LV bar, by its, the impella bar, by its suction to the LV, it will decrease the LVEDP, so decreasing the cardiac work and decreasing the MVO2. In the other hand, you will, by decreasing the pressure, the LVEDP, you will decrease the microvascular resistance, so improve the oxygen supply. Also, by decreasing the LVDP, of course, we will decrease the wedge pressure and we will increase the oxygen supply. On the other hand, with the ejection, we will have 3.5, 3.7 liters, so we'll increase the cardiac output, we'll increase the cardiac power output, and we will increase the tissue perfusion, including the coronary perfusion. So we can say that the impella is really an ideal mechanical support because you will be supporting the circulation and supporting the heart itself. At the opposite, if we compare that to the ECMO is an excellent circulatory support. It will give for the peripheral one 4 liters, for example, but it is an extremely bad cardiac support because you will be increasing tremendously the afterload, ballooning the heart, creating some thrombi, and delaying the healing of the heart, especially in an MI patient. And from here came the idea to associate the impella to the VA ECMO in patients who are in cardiogenic shock, and that's what we call the ECMELLA or ECPella. We'll discuss that later on. So this is for the device itself. Now, who are the patients who can get benefit from impella? We have mainly 2 on-label FDA-approved indications. The first one is when we are anticipating a hemodynamic instability. And these are mainly the patients who have, they will be submitted to, they will have a high-risk PCI. And the second indication is when you have an overt hemodynamic instability, essentially exclusively due to a cardiogenic shock. So for the first indication, I would say Dr. Khaled explained that very, very well. It is summarized to what is a high-risk PCI. You have criteria related to the patient's coronary anatomy, hemodynamic states. These are SHIP patients. We have multiple algorithms, scores to dictate our management plan. But I personally think that whenever we think to protect our PCI, we have to protect our decision. And to protect our decision, we should move from a personal-based approach to a heart team-based approach. So here it's very, very important in these patients to support the decision with the heart team discussion. In the second scenario, the second case, it's much more difficult. It's almost sometimes extremely difficult to gather a heart team at 2 o'clock night. And it's even more difficult because the clinical scenario is more granular here. You can have different patients, different type of shock, different stages of shock, different severity of shock. It's different if you have a patient who is coming early in the shock and from a patient who is coming very late, a full blunt cardiometabolic shock with multi-organ failure. So it's nice to stratify our shock severity, but it's not enough actually. We need to have a full picture of the phenotype of our shock. Having a cardiogenic shock with an RV failure, these patients will never respond to impella. You have to think about something else. Having a mixed shock not only cardiogenic, but with the vasoplagic reaction, what we have usually after a prolonged CPR, these patients will not respond enough to Impella, and you have immediately to think about upgrading to Icmilla. So it's extremely important to get that in knowledge before starting the procedure and to expedite the management, because we are alone in the ER, so we have to have expeditive mechanisms. So the key point here is to build the cardiogenic shock team and to build protocols. And this we learned actually during our process. You have in the literature multiple very excellent, I would say, protocols that can help establishing a proper protocol that is adapted to each institution. These are in-label indications. Off-label indications, we have fulminant myocarditis, post-pericardiotomy, cardiogenic shock, VT ablation, Icmilla, Icpilla, and there is a new indication, which is the protected cardiac surgery. Like we have protected PCI, we can have protected cardiac surgery. For the contraindications now, we have the contraindications for all left mechanical support, futile patients, coagulopathy, moderate to severe aortic regurgitations, and you have contraindications for the Impella itself, which are LV thrombus, mechanical aortic prosthesis, cardiac tamponade, RV failure, if you have thinking just to implant, to put an Impella left side. And in the IFU of the product, you will find ASD and VSD as contraindication, because we thought that it will create a right to left shunt, but now there are multiple reports that are advocating the role of Impella in post-MI VSR. Now we come to the implantation of the Impella. So some best practice, of course, Dr. Khalid, he explained that very well, the selection of the access site. In case of high-risk PCI, we have the time. We have the time to do an ultrasound, to do a CT, to select if you can cross if you have more than 5 millimeters, but sometimes it's a cardiogenic shock. So you are limited to the ultrasound that you have in the cath lab. So in the best practice, and this is what we are doing very commonly, all the femoral approaches are ultrasound guided with micropuncture. You assess the vessel, and then if the vessel is more than 5 millimeters, we go ahead and prepare the access site, pre-closing with 2 proglides, or we can skip that step if we are going to close with a manta. So then we will insert our sheath. So this is what you call a peel-away sheath. It comes with the system. We have two different lengths. We have a 13 centimeter and 25 centimeter length. We are most commonly using the 13 centimeter because we found that it's offering less resistance and friction when we are using a single axis. So this is what we do. We cross the aortic valve with the pigtail, taking precautions not to be entangled in the subvalvular mitral apparatus. We leave there the 0.18 shaped wire. We are the one who will pre-shape the wire. It's a wire that comes with the machine. Then we will introduce the Impella with taking precautions not to touch the inlet or the outlet. So this is the Impella coming. And we take our precaution to insert it toward the LV apex. This is an Impella with a good position. You see the level. This is what we have seen previously, the radio-opaque marker at the level of the aortic valve. This is a deep, bad, I would say, very deep pigtail Impella. You see the motor housing is at the level of the aortic valve. So we are sucking in the LV and ejecting in the LV. The second thing that it's quite recently described, it's not only a question about position, it's a question about rotation as well. So the Impella has to be oriented toward the LV apex and not entangled in the mitral valve apparatus like here. So position and orientation. This is a good example of well-oriented pigtail. We verify that in RAO or caudal views and in iliocranial view, you see here we are nicely toward the apex. We have to be toward it, not necessarily in the apex, but in the direction of the apex. This is a bad crossing. You see crossing only with the wire. And look at the pigtail, the impella, how constrained it is in the mitral valve subvalvular apparatus. Look at the position, how is it? We are in the mitral valve here. And this is another case. It's not in our institution. It was even published. Look at this extremely bad position and bad orientation. And this kind of malorientation has been associated to multiple complications, including stroke, actually. So once we implanted our impella, we can start our procedure, and we can use, it's interesting to know that we can use the same access, we can to do the procedure. What about if we have problems of access? This is a patient who have no right femoral option, no upper limb options, and we have a severe lesion there in the iliac, the ostium of the iliac. We stented the iliac. We crossed the iliac with our system. Look at the impella, how easy and safely it crosses the stent. We crossed with our guiding catheter because no other options. And we safely pulled back at the end the pigtail. Of course, we couldn't just do a ballooning because these patients, you have to think about after. If you have to leave the impella there for any hemodynamic persistent instability. A second case, here it's another more complex patient, an occluded abdominal aorta, occluded subclavian artery, a surgical turned down patient. So we collaborated with our vascular surgeons to put a graft in the subclavian artery. And look at that difficult band we have. We had a lot of difficulties to cross with the pigtail, so we make it more straight with the backup Meyer wire here. We introduced our pigtail from there, our impella from there. We did the procedure, removed the pigtail, and here is the problem. And this is one of the painful lessons that we learned, because we have not included our vascular surgeons in the program from the beginning. We have not taken them to there are some specific dedicated courses for a subclavian approach. So whenever we have to think about starting a program, we have to think about including all people who will be involved in the program. Once we finish and we have to leave the impella device, we peel away the sheath and we put this reposition sheath here. And the problem is that this reposition sheath is a 13 French sheath, and I will come back for that. A very, very important point and step here is to rotate clockwise the TUI valve here to maintain the impella not to move. So we fix clockwise this TUI valve, and we fix the sleeve to the sheath. And as I said, the peel away sheath is a 14 French inside, 18 French outside. And the repositioning sheath is a 13 French inside, 16 French outside. Move the peel away and put the repositioning sheath, we have a risk of bleeding around the sheath. And this is very common. And this is killing. This is really the Achilles heel of the impella. And the company actually is given a lot of tips and tricks, pulling the wires, maintaining the sheath at 45 degrees, but I can tell you nothing works. If it will bleed, nothing will work. And now we are copying almost what high volume centers are doing, that we are leaving the peel away sheath there. Now your patient is coming to the ICU. We have to have a check-in assessment. So first, and very importantly, we have to look at the TUI valve. Is it really locked? We have to see if that angulation is maintained. Verify the position. in the positioning, in the placement screen, and by echo. And by echo, the best view will be the parasternal long axis. We will measure the distance between the teardrop and the valve. So it has to be 3.5 to 4 centimeters, and your impella shouldn't be like that, shouldn't be rocking. It has to be more stable. So I discussed that regarding the position. We have some tips and tricks. If you are fully in the aorta, we can pull until we have an aortic pressure. If we are in the aorta, actually it's more difficult sometimes. If the pigtail is still in the LV, we just push the impella. But the problem is that when we are completely in the aorta, here it will be very difficult. And this is one of the patients, this is our first cardiogenic shock patients, and here also a painful lesson that we learned. The impella is here, nothing get knowledge about that until late. So we managed to push, but very gently. We shouldn't push forcibly because otherwise we will kink the impella or we will damage the aortic valve. So here it doesn't work. So we managed to snare the impella, to bring it toward the aortic valve and to try to change the orientation. It didn't work. So we get down in the LV and we snared the pigtail to bring it down. So here also, lesson, we didn't include our nurses and our fellows to follow and to follow clear the patients in the CCU. We assure we check for the volume states of the patient. You know, the impella is preload dependent, afterload sensitive, so we have to assure a good and adequate afterload and preload. Don't have the time. And we check for the urine for any signs of hemolysis. Last, we check for the complications. The most frequent complications are bleeding and ischemia. So to prevent these complications, we have to be proactive. Proactive means to address all the alarms promptly. We shouldn't neglect any alarm. Regarding the bleeding access site, we have the precautions of keeping the positioning sheath at 45 degrees. We have to monitor very carefully the heparin level. The ACT shouldn't be more than 180. In our institution, we shifted from heparin to bivalirudin, immobilizing the knee, many other, some tips and tricks to manage the bleeding, but currently we are leaving the PLOA sheath actually. When we leave the PLOA sheath, we have to think about early recognition of limb ischemia, and if we have any signs, early signs of limb ischemia, we just put a distal perfusion cannula. So the key messages to conclude is whenever we are planning to start an impella program, actually the most important key point here is to prepare the team, to get a full team prepared, nurses, ICU, CCU, echocardiographers, fellows, anesthesiologists, everyone has to be ready. You have to prepare our protocols, involve the company for training. I would advise to start with high-risk PCI, don't start with cardiogenic shock patients, and do a root cause analysis, debrief your first 10 cases, because always we learn more from our patients. Thank you so much.
Thank you, Hatem, for this brilliant presentation. You didn't at your lunch, but you at our time. Thank you for being. We have room for a couple of questions. It is an amazing session, an excellent session, and I think that we have 2 questions. The first question is for Wael. It's an encumbersome system, 14 French, as Hatem said. He put the impella in a tight aortic stenosis, in a cardiogenic shock. How did it to cross the valve and not to probably damage the patient hemodynamics?
So at the beginning, we used to thought wrongly that if we put the impella, which is the 14 French, across the tight aortic valve, that will compromise the hemodynamic. Of course, it's an off-label, as Hatim indicated. There is some indications it's off-label, but we found that it is doable and it gives us a good support. So it comes from building experience. It's not something, like there is a study about it. It will give you a good support, and trust me, it's a good modality.
My second question is for Dr. Khalid. Dr. Khalid, you did nice procedures, a complex, nice procedure. But regarding guidelines and according to guidelines, we have to stick to only the culprit lesion in cardiogenic shock. And in your case, it was the proximal LAD. You can't manage the proximal LAD without managing the left main. But you did the circum, you did the distal circum, etc. It's off-label. Without impella, you've done only the LAD in the LAD with the distal left main, or you've done the same thing even without impella?
Okay, thank you. I think if we don't have impella, I will just make it as simple as I can. But with the presence of impella, so I'm supported now. So I have to do complete revasc for that patient. For my patient, if there is no impella, I will just go with the provaginal as the patient in cardiogenic shock, and then I will assess the LCX. If the LCX has TIMI 3 flow, I will just bring him in other session, and then I will reassess him again. No, because no complex PCI without impella, because this is a long procedure. Maybe just a question to Dr. Weil. So you just mentioned in your presentation that the 30 days mortality is high in patients with cardiogenic shock, and they have the same mortality after 1 year. So what is there any explanation for that?
Actually, if you look at the papers and publications, it's how aggressive you are is the most important. Like patient with cardiogenic shock, don't wait or delay impella, don't wait and delay ECMO. They are the most sick patient. So you have to be very, very aggressive with all your tools, and make up your team around you, and don't lose the boat. And that's the message.
Thank you thanks a lot for this excellent session. Thanks a lot for this excellent session. This gives us the opportunity to be in the TCT Middle East, because we have an excellent team preparing the TCT for us, and we have to leave the stage for the HFA and the UZ group. We have a nice session about heart failure, and I ask the moderator and the panelists to be here. Magdi Abdel Hamid, Ikram Kamoun, Madam Krayim, Ihab Laban, Si Ali Nayhoum, and Dr. Sharfuddin. Thanks a lot.